Hello and welcome back to the Neurotransmitters. I'm your host, Dr. Michael Kentris, and I'm really thrilled to be recording today's episode as we are rejoined by friend of the show, Dr. Andreas Charidimou. And today we are talking about a topic that I find very fascinating, very challenging, and that is amyloid spells. Thank you again for joining us today, Andreas.
Thank you so much for inviting me again, and I'm thrilled to talk again about one of my favorite subtopics in CAA.
Yes. Now, just before we were hitting record, you were saying that, obviously for those who know you, you are, very well published in the arena of amyloid angiopathy, cerebral amyloid angiopathy. And you were telling me that during some of the talks that you get, whether or not you mention it directly, one of the topics that comes up time after time is these amyloid spells. So could you just tell us a little bit about what is an amyloid spell and when should we be considering that on our differential diagnosis?
Yeah, sure. So historically and traditionally, the presentation that most people have linked with cerebral amyloid angiopathy or CAA is that of lobar intracerebral hemorrhage. And this has been known for at least 30 to 40 years with the advent of neuroimaging. One least known presentation, at least as of 10 years ago, is these presentations with what it used to be called amyloid spells or transient focal neurological episodes related to CAA. And as the name implies, these are episodes that are transient, neurologic in nature, and focal. And the prototypical descriptions of these episodes are basically positive symptoms. Paresthesias, pins and needles feeling, which are migrating. And the syndrome that was first described and is more characteristically associated with symptoms is spreading positive sensory symptoms in the arm up to the mouth and then slowly going back to normal in the same fashion. However, there is a spectrum. Essentially, this from a symptomatic point of view, it includes any transient symptoms that they might look similar to TIA. So there might be negative symptoms, speech impairments, focal weakness, arm or leg, or they can resemble auras, visual auras typically, that they might remind you the auras that you typically see with migraine. And as you can tell, it's a tough. It is a tough symptom to link directly, tough phenomenology, and not specific to link directly to CAA, because the differential is broad when you see transient symptoms of any nature in neurology. But when you should be suspecting this, I think, is in any patient that is on the older spectrum of age. So any patient older than 55 or 60 years old coming with transient symptoms, you should be thinking, when you think about TIAs, essentially you should be thinking whether this is CA-related phenomenon. And one of the characteristics which differentiates this from TIAs actually is that these episodes are multiple and stereotypical, whereas a TIA typically is going to, you're going to have the episode once and then probably a different kind of focal phenomenology if the patient has a second TIA. So in that sense, it resembles a bit focal seizure activity, because focal seizure is another differential when you see a patient with recurrent episodes and you think about TIAs, but it's too stereotypical, happened too many times, so you might consider that this is a focal seizure. So in that context, I think you would consider CA-related amyloid spells.
Yeah, I'm going to have to update my lecture that I give to trainees about the differential diagnosis for first-time seizure events to include amyloid spells. But that is one of the tricky things, right? We always talk about, like with migraine, with seizures, this kind of spreading cortical depression, all this kind of stuff. And it almost sounds kind of like that same kind of phenomenon in this situation. And I know it gets even hairier when we start talking about like things in the epilepsy world, like negative motor seizures and things of that, which are also stereotyped. So one other thing you had mentioned is that, whether these are focal dysfunction versus like, is it actually edging into the territory of causing seizures? And when do you start to consider one versus the other, or how does that kind of affect how you approach these patients?
Yeah, it's a tough question. I think taking one step back, essentially, the question is what is the pathophysiology of these symptoms?
Ooh, yes, excellent.
And the answer is that we don't really know because we haven't studied this phenomenon from from a pathophysiological point of view. What happens is that behind these symptoms there is typically superficial bleeding in the form of a convexal subarachnoid hemorrhage in the acute phase when this phenomenon first occurs, or cortical superficial siderosis, which essentially reflects vessel wall cracking in the leptomeningeal space due to CAA, leading to even one drop of blood on the surface of the cortex, which it creates a lot of irritation. So what it has been suggested as a mechanism based on how stereotypical these episodes are, the positive phenomenology and the spreading pattern, along with the timing of this spread, is this might resemble a mechanism similar to cortical spreading depression. Because in cortical spreading depression, you have a slow wave of excitation, which then is followed by total inhibition of cortical neurons. And this might correlate in some of the symptoms with the spreading excitation creating the positive symptoms. And then slowly, for example, if you have pins and needles going from the arm up in the mouth, and then slowly those symptoms going away. But this is like a theoretical assumption about the pathophysiology. Now that we know that there is a huge spectrum of these symptoms from positive to negative, I'm thinking that maybe the negative symptoms might be focal seizures. Again, maybe initiated by the irritating aspect of having blood on the surface of the brain, or sometimes having acute microbleeds in cortical areas that are symptomatogenic. And there is some indirect evidence that we should be thinking about a seizure mechanism. There was a recent study from Mayo Clinic and another one from Italy where they look at the prevalence of epilepsy in patients with CA specifically. And they did EEGs and they found that the factors associated with epilepsy and focal seizures specifically based on EEG captures in CAA is the presence of cortical superficial siderosis, which is very common and underpins these amyloid spells, and the patient having inflammatory CAA. There is a different kind of mechanism because inflammatory CAA is it's a different kind of disease with brain edema and inflammation. So I think the bottom line is, and the message that I want to send is that probably patients presenting with transient focal neurological episodes, they don't get enough EEGs. And this is underutilized in many centers. Even when you do the brain MRI and you see an area of acute subarachnoid hemorrhage or siderosis, even when you ascribe this to being CA-related, I think an EEG would still be useful because it's going to change the symptomatic management of these patients.
That makes sense.
Yeah.
Now, and again, I don't know the data well enough. When we look at, and maybe the data isn't there, when we look at EEGs in patients with CAA or suspected CAA, plus or minus the transient focal neurologic events, like, is the sensitivity, like for, say, a routine EEG, still that kind of that, proposed around 50%, in which case, like, a positive result is much more useful than a negative result, and perhaps you might treat regardless if there is a clinical history of recurrent stereotyped events, particularly with positive symptoms.
Yeah, so I don't think the data are there. I would assume that the sensitivity should be similar to the sensitivity in other focal seizures. So if you capture something, I think it's very useful and a positive indication. If you don't capture anything, you might consider repeating it if the symptoms recur, or use your clinical judgment on how to manage this. in most of these patients, the symptoms tend to resolve on their own, presumably as the blood gets resorbed. However, I think it makes sense in patients with negative symptoms to look a bit deeper for a focal seizure focus, and also in patients even with positive symptoms when they get too many of these. I mean, I have had patients having 20 episodes per day. So these are interfering with their life. So in those patients, you might consider a low dose antiepileptic, which you would keep the patient on for 3 to 6 months with the aim then to remove it as the symptoms subside.
Okay.
But this is just for the symptomatic aspect of things. The importance of these episodes are not the symptoms per se, but is what they indicate. And they indicate bleeding on the surface of the brain, which is dangerous in the setting of CAA. So that's that's the second layer.
So hypothetically, so let's say we have a patient who, they come in with a kind of TIA-like event, an episode of, face weakness or numbness or what have you, that resolves spontaneously. We get the MRI done, and it shows maybe, a small microbleed that would, localize appropriately. But they've only had one event, and let's say they're following up, in the neurology clinic 3-6 months later, and when they come back, now they're having these events recurrently. So kind of a change in frequency, if you will. Would it be appropriate in those patients to repeat imaging to see, is there a recurrence of a microbleed at that point in time?
Totally, yes. So if you have the diagnosis of CAA-related TFNEs, if there is a silent period over 2-3 months and then the patient presents again with even the same symptoms, I think it's a good indication to repeat imaging to see if there has been a new bleeding event. In patients that you have diagnosed, they have been having recurrent similar symptoms, you don't necessarily need to repeat imaging. But if one of those patients presents with a totally different symptomatology, then again, the question is, have they had a small bleeding in another area? Because these symptoms are basically, is like a clinical marker of fragility of the leptomeningeal vessels in CAA. And this is a patchy disease, which means that there might be other small bleeding events in other areas. So yes, this is exactly the patient population that you're going to have low threshold to reimage, because it's the only way to see what has been the progression.
Gotcha. No, that makes complete sense. And I think that's a great point to emphasize, right? That CAA is a progressive neurodegenerative condition. So we should expect this to be kind of a moving target for a lot of patients.
Also, the other relevance of this is that, let's say you have the patient you mentioned coming to the emergency department with some sort of stereotypical transient neurological symptoms. Most clinicians at the top of the differential, we're going to have the TIA, right? And not all patients will get immediately a brain MRI, because to diagnose this as amyloid spells, you need brain MRI with blood-sensitive sequences. Now, the big clinical implications in this scenario is that if you think the patient has a TIA and you don't have a brain MRI, what's the treatment for typically a TIA? You start antithrombotics, right?
Yeah.
And then you do the workup. However, if this was indeed an episode of CAA-related TFNEs due to a small acute subarachnoid hemorrhage, by prescribing antithrombotics, you're pushing the patient to bleed more, essentially.
Right. And would this be a common scenario? Because I've encountered this once or twice myself. Obviously, at a smaller institution, our volumes aren't going to be quite as high, but where we have someone who comes in, it sounds like a TIA, and then you get the MRI and you see maybe they don't meet full criteria for CAA, but they're kind of in that possible camp where you've got a microhemorrhage in, maybe they came in with aphasia and it's kind of in that left temporal or frontal area. And you're like, was this an amyloid event? I don't have enough necessarily. I've got him on dual antiplatelet therapy right now. Maybe I should de-escalate that to maybe just like a low-dose aspirin.
Yeah, we can discuss all sorts of different scenarios, but
Right.
let me put it this way. Even one such patient, if you get a brain MRI, even if the patient fulfills criteria for probable CAA, it doesn't mean that the episode is due to CAA. I think the highest level of certainty is when you see siderosis or subarachnoid hemorrhage in an area corresponding to the symptoms.
Mm-hmm.
In that scenario, you can basically say that probably it has something to do with that acute bleeding. And we can discuss later, but there is a whole differential of convexal subarachnoid hemorrhage. It's not, the message should not be you see it, it's CAA. It has a huge list of potential diagnoses. Now, if you only see a microbleed but is in the right spot, I think you should pause and think whether it's related to that, and maybe look for other less sensitive markers of CAA. If this is a microbleed in the right spot and the patient has severe perivascular spaces in the centrum semiovale, or they have these small subcortical white matter spots that are included in the Boston criteria, it kind of raises the pretest probability of this being related to the symptoms. In any case, you would still need to do a full workup for a TIA, because if on that side you have a carotid stenosis, then obviously the plot thickens, but you need to address that as well. So
right.
In some patients, it's very difficult to have the exact set diagnosis, and there are cases that at 1.5 Tesla using GRE, you might see only a microbleed, and then you repeat imaging on a 3 Tesla MRI with an SWI, susceptibility weighted imaging, and then you see that, oh, actually there is a tiny spot of siderosis. So imaging is not, has different.
It's not all created equal.
Yeah.
No, that's a great point. And I know our institution just started using SWI sequences in some of their protocols, thankfully. So that has been helpful. So we're kind of finally coming into the 20th century a little bit. But yeah, no, I think that's a great point. And I've certainly had those patients, as you intimated, where maybe you've got a little bit of hemorrhage, you've got a bad carotid, maybe they also have a history of epilepsy too. And you're like, well, which one of these is the culprit this time around? And it does become very, very challenging.
Yeah, it is very challenging. And we don't know what's the size of the problem. In other words, how many of these patients are missed? How many are they diagnosed as TIAs or as focal seizures? The only study that I'm aware of is a study from Calgary, where they went retrospectively and they look at their TIA registry. I think they had around 400 patients, and they reviewed the MRIs to see how many patients fulfill Boston criteria for CAA, and in how many of those there was an area of bleeding anatomically corresponding potentially to the symptoms. And I think they reported that in about 1% of their total population, actually retrospectively, they thought that those were actually not TIAs, but they were transient focal neurological episodes due to CAA, which it doesn't sound like a huge number, but if you put into perspective on how common TIAs are, the absolute number of patients getting misdiagnosed, especially in centers or countries that MRI is not part of the initial workup, then this number is pretty high.
No, that's a great point, especially like you said, in rural areas. I know that there's different protocols, like where you get the CTAs to make sure there's not a hot carotid or anything like that, and you kind of work them up over the next 2 weeks as an outpatient.
Yeah,
but yeah, that's a great point. There are certainly things that will not be captured.
Yeah.
Kind of doing that, low resource triage.
And actually, my involvement in CAA started by seeing one of these patients. There was a patient that came to the emergency department of University College London at the time when I was starting my PhD with a lobar hemorrhage. And when we looked back a few days before the patient presented to his PCP, a primary care physician, with some sort of transient episodes, positive in nature. I think the left arm was affected and up the mouth. And at the time, I don't know if it's still the case in the UK, the protocol was that the patient gets a CT, you initiate antiplatelet therapy, and then they go to a TIA clinic at some point. And this is what they have done. When we saw the brain MRI, close to the area of the hemorrhage, there was an area of acute subarachnoid hemorrhage and some chronic siderosis, also in remote areas. And if you go, when we went back to the CT, we actually saw that there was a tiny bit of blood in the right sulcus. And at the time, I had no idea what that was. And my PhD supervisor, David Waring, he says, "Oh yeah, this is probably amyloid spells." And looking in the literature, we realized that there were just some case reports of this phenomenon. And this is how we started assembling a multi-center cohort to see indeed if this is a common phenomenon, what are the symptoms, what are the symptoms, and what is the risk of bleeding. And this is how siderosis actually gained validity in the CA field as a good imaging predictor of the disease and the risk of bleeding through these TFNEs or amyloid spells.
Fascinating. Yeah. And I was telling you before we started recording, I've only really had these in my consciousness for about 3 to 4 years myself, which, going through like epilepsy and things like that, I would expect to have, transient neurologic events are kind of our thing. So I would have really have expected to have heard more about them. But it is one of those things where it's kind of the most common disorder you've never heard of, as how it feels.
Yeah. I wonder if some patients, they might have a very brief episodes. They don't even seek, medical care. And some of them, they then, develop a hemorrhage, or they might not have any other symptoms for a good period of time. So those are totally missed.
No, it makes complete sense. And so one thing that I've been kind of curious about, if you're willing to speculate wildly with me, we know that there's a lot of anti-amyloid therapies, kind of coming into the public consciousness these days, with, like aducanumab, lecanemab, all those kinds of things that are these anti-amyloid types of treatments. And, we know that there is this inflammatory subtype of CAA. How, or if, do you think there is any pathophysiologic relatedness between kind of the ARIA, right? These inflammatory adverse effects that we're seeing with some of these anti-amyloid therapies, as opposed to these like transient focal neurologic events that we see in the context of CAA versus like Alzheimer's disease in general. I know it's a very broad question for which there's not a huge amount of literature, but I'm just curious what your perspective may be, if you have
Why are you asking this question? Have you seen a patient that made you wonder about inflammation in the setting of transient spells? Because your question is very at the point, I have to say.
So I have had a couple inflammatory CAA type patients come in. They kind of almost have that tumefactive or neoplastic look on the initial MRI. You repeat it again, 3 to 6 months later, and it's quieted down a bit, some residual hemorrhage there. But they will come in sometimes. Sometimes they will come in like maybe in focal status, or maybe have had a seizure at onset, things like that. And then we've got these ARIA episodes with the anti-amyloid therapies. And there's, again, right, these kind of various neurologic phenomena that tend to occur, whether those are visual, sensory kind of disturbances. And it's, it just seems too close to be coincidence, just from an observational perspective.
You're totally right. I think if we put it simply, a bit simplistic, but I think it works for our discussion, is that ARIA is basically iatrogenic CAA-related inflammation. The two are, mirror images. One is caused by a treatment that we do. The other one occurs spontaneously. So essentially, we can learn a lot from CAA-related inflammation, because many of those things probably apply to ARIA, including the spectrum of the disease. So CAA-related inflammation, typically it was considered a condition that during which the patient will be very severely affected. An encephalitis kind of picture with changes in the level of consciousness, seizures, commonly with status epilepticus, and basically these patients will end up in the neuro ICU. And on the MRI, CSF, all the workup, you will, and often a brain biopsy, you will land on the correct diagnosis. Now, I think with greater awareness and more widespread use of brain MRI and blood-sensitive sequences, we're realizing that this is only the tip of the iceberg. There are patients with CAA inflammation that they present with minimal symptoms. At the milder end of the spectrum, I think are patients with CAA inflammation that they present with amyloid spells. I have no idea how common this presentation is, but for the past year, I have encountered 3 patients. These patients, they presented with positive or negative symptoms, transient, stereotypical. On the brain MRI, there was evidence of bleeding in the right area. And these patients, they kept coming to the hospital with more episodes and more acute bleeding in that same area, which makes you wonder, this is not the typical wild variety of amyloid spells that they will have one episode and then things are going to go silent. There was evidence of something going on locally. Vessels keep bleeding. I think in these patients, completely anecdotally, a contrast study will be useful, because in these patients that I mentioned, a contrast study showed leptomeningeal enhancement in the very area that was bleeding, which makes you think if there was an inflammatory element. And in fact, 2 of those patients we treated empirically with corticosteroids. And there is no control group, but the patients are doing well and they haven't had any bleeding since. So translating this to ARIA is also a spectrum from asymptomatic, so just imaging manifestation, which, by the way, I think is the only case that should be called ARIA. Is the only, asymptomatic is the only scenario that you should be calling these amyloid-related imaging abnormalities. When the patients are having symptoms, there are no imaging abnormalities alone any longer. They come with a symptom. We should have a better name. But in any case, some of those patients, I believe they might present with transient episodes due to maybe sulcal hemorrhage, or maybe fluid extravasation or edema focally. Now, we might not encounter those patients very often, because when a patient is on lecanemab, let's say, these patients are monitored pretty closely with serial brain MRIs, typically after the 4th infusion, after the 7th infusion, and this is when ARIA has higher likelihood of happening. In other words, you might capture ARIA on imaging before it started manifesting with symptoms. But I think it is possible that some of these amyloid spells, especially if recurrent and different types, or even the same types, sometimes they might have an inflammatory basis with or without anti-amyloid treatments. This is something that is a completely new realization. There are only a couple of case reports, I believe.
Interesting. Because I have wondered in the past, because if I remember correctly, a history of intracranial hemorrhage of various types is kind of a contraindication to starting these anti-amyloid therapies. So are we causing this, or are we unmasking it with some of these anti-amyloid therapies? I don't know if there's a good answer to that.
It's a very good question, first of all. I think in some patients, the anti-amyloid drug is like a crash test to reveal if there is underlying CAA. because it's going to push the patient to express the cerebrovascular amyloid pathology. And for ARIA, I mean, we don't really know what's the cause, right? There are two predominant hypotheses. The first one is that either the anti-amyloid antibody binds directly to the vascular amyloid with different affinity, but still binds there, inducing inflammation and vessel wall breakdown. Or alternatively, as the amyloid plaques and the antibody and the inflammation kind of gets broken down, some of that needs to be removed from the brain via the perivascular space. And the perivascular space is the scene where amyloid angiopathy also manifests. So there is a problem with the perivascular drainage in patients with CAA. So those, again, simplistic like hypothesis is that these breakdown products, they get clogged in there, again, inducing inflammation. So essentially, one of the primary risk factors for developing ARIA is having underlying amyloid angiopathy. And this is reflected indirectly both in the appropriate use recommendations and in the FDA recommendations when they say you shouldn't be giving these treatments to patients who have 4 or more microbleeds or to patients who have siderosis. Essentially, indirectly, you're saying you shouldn't be giving these patients when it's very obvious they might have evidence of advanced CAA. But many patients have either fewer microbleeds or more silent CAA, and then you do the crash test. So these patients needs to be very carefully selected and obviously very closely monitored.
That makes good sense. Something you mentioned earlier is, it seems like a lot of the emphasis on kind of these transient focal neurologic events is related to more of the superficial siderosis, so the kind of that cortical surface. But we need to not anchor on that too much. So you mentioned that you have a differential diagnosis that you kind of work through when you see these cortical bleeds. What kind of things also go through your mind as far as potential underlying etiology?
Yeah, so I think we can approach this first. Obviously, you have a differential diagnosis of the episodes themselves. And we mentioned TIAs, especially for a first comer with these episodes. So TIAs, focal seizures, migraine with aura, sometimes metabolic abnormalities. I mean, I'm sure you have seen patients with hypoglycemia who have focal symptoms, functional neurological disorders. So there is a whole differential just based on the clinical symptoms and the context. And then based on imaging, if you see acute subarachnoid hemorrhage, there is a whole different differential diagnosis, which includes things like small AVM, any sort of vascular malformation causing the bleed in that area, sometimes small aneurysm. You can have endocarditis causing an aneurysm there, inflammatory again in nature, or septic embolism and causing the bleeding. You might have RCVS, which can cause convexal subarachnoid hemorrhage. There, the age is a good indicator. For example, the most common cause of convexal subarachnoid hemorrhage in someone younger than 50 years old is typically RCVS, whereas the most common cause in someone older than 60 years, it's amyloid angiopathy. Then you can have IV drug use. Cocaine, heroin can cause, via a similar mechanism to RCVS, convexal subarachnoid hemorrhage. So for that, again, the clinical history and what are the other imaging findings are going to guide you on what might be the underlying diagnosis. Do you see other areas of chronic superficial bleeding, any other areas of siderosis? Do you see lobar microbleeds? In other words, is there evidence that there have been similar bleeding events in an elderly individual solidifying your differential that this might be CAA. But again, you keep an open mind because you still need to do a workup for the rest of the patients, including vessel imaging.
No, that makes complete sense. Now, something you mentioned about some of these people with recurrent, sometimes disabling, or very frequent episodes that are disturbing to them, potentially. You mentioned you'll put them on an anti-seizure medication for sometimes a dedicated period of time, like 3 to 6 months. Is it likely that after the acute hemorrhage, that when you wean them off the anti-seizure medication, that these spells will not recur? Or do you find that this is more of a lifelong anti-seizure medication for some patients?
Yeah, so this is kind of different with patients with focal seizures in that the idea is that these episodes, unless there is more bleeding, they will tend to subside because the blood will get absorbed into hemosiderin and it's going to be less irritating. So the majority of these patients will have resolution of the symptoms over a period of the next 3 to 6 months. The idea of putting someone on an anti-epileptic patient, with CAA-related TFNEs, is twofold. First, if you have identified a focal seizure on EEG as the mechanism and you believe this is just CAA, then you would put the patient on anti-epileptics. If you haven't identified that mechanism, which I guess is your question, if there are multiple episodes, you're going to put this patient on an anti-epileptic with the hope that it might help with quicker resolution, and with the idea that as soon as the episodes gets resolved, which might relate to the natural history of the condition, then you try to get off the patient from the anti-epileptic. It's not going to be for life. So typically, the longest I have used anti-epileptic in one of these patients is up to a year.
Okay.
No,
that's good to know.
So then you take them off. I'm not even sure if the anti-epileptics were doing something or the symptoms were deemed to get resolved.
Their natural history taking care of itself. Yeah. No, that's a good point.
There are some people that try to use anti-epileptic medications that there is ex vivo. There are ex vivo data that they actually might affect cortical spreading depression. I think lamotrigine is one of them.
More in the sodium channel family, I would imagine. Yeah.
So that's another rationale that maybe with some anti-epileptics where you're targeting cortical spreading depression in addition to epileptogenicity. So, but Keppra, I think, as in many other areas of neurology, is often the go-to medication. 500 milligrams,
right? Just plug and play
twice per day, which is a low dose, but still a good dose in an elderly individual. Lacosamide is the one I used as well.
Okay.
Again, completely non-evidence based.
Right. Well, I got to start somewhere.
Yeah, right? And this is a rare scenario to have so many episodes that you're going to start an anti-epileptic. It's like maybe 10% of all the CAA-related TFNEs. You're going to need to do that.
Gotcha. Yeah. So my takeaway as far as like anti-seizure meds would be recurrent stereotyped episodes, maybe more of a preponderance of positive symptoms. And, if they're disabling, obviously, and you find no evidence of, like in the absence of recurrent bleeding, would you say, or plus or minus?
So I would go purely by the recurrence of clinical symptoms.
Okay.
Now, if there was a recurrent bleed without any evidence of either a new seizure or a new episode, there is no indication to continue anti-epileptics. You wouldn't do it prophylactically.
Okay. Because I know there's a little bit of debate out there for like some of the intraparenchymal hemorrhages about prophylactic anti-seizure medications, but I see a lot of, because sometimes these consults will come more to the neurosurgeon than to the neurology team as far as like a small subarachnoid hemorrhage. So everyone gets put on Keppra or something like that for 7 days, kind of like the traumatic brain injury type dosing.
I guess it varies between institutions. So
right.
Yeah.
But no, those are all very helpful points. I really love the tip about using the contrasted MRI. It's not something I think about with these types of patients with when I'm kind of doing the TIA or CAA kind of evaluation. But I'm going to definitely keep that one in my back pocket going forward.
Yeah, especially when you see a patient that is a bit different or atypical to the patients you have seen before with these episodes.
Any other questions that you find come up a lot from people asking you about amyloid spells or the TFNEs that you think would be useful for people to know about or would help them identify these patients?
I think there are two questions that they have been coming up a lot. The first one is, okay, the patient comes to the ED with these symptoms, you do a brain MRI or even a CT initially, and you see there is an acute subarachnoid hemorrhage. How do you treat this patient? And my answer is that it's reasonable to send this patient to the neuro ICU with the aim of, essentially, you should treat it as a hemorrhage, as a brain hemorrhage, intraparenchymal hemorrhage, in terms of lowering the blood pressure, having a very strict target, closely monitoring these patients for any recurrence of the bleeding. And it might be a short stay. It might be just one day, just to control the blood pressure if it was high and have a more definite diagnosis. So this again depends on availability in each individual center. But I think the blood pressure in the acute setting in the first 24 hours is a reasonable target to have in the management of these patients. So this is in the acute setting. The second question that comes up very often is, what is the risk of these patients having a lobar hemorrhage? And what do you do when you find out that they have AFib or they have another indication for anticoagulation, which is something that we discussed in the previous podcast. But I think the overall approach is that these patients, again, they should be treated similarly to a patient who had a lobar hemorrhage due to CAA in terms of the future risk of hemorrhage, because it's not that the amyloid spells increase the risk of future hemorrhage. The reason that these patients have high risk of hemorrhage is that they have a lot of cortical superficial siderosis. So the imaging manifestation is a biomarker of severe or advanced CAA. So it's likely that, very stochastically, one of these small vessels will pop, and the hemostatic mechanism might not be enough to seal the crack, and these patients might end up with a lobar hemorrhage. So we know from observational studies that these patients, they might have risk of future hemorrhage from 15 to 20% per year. And the risk, you can kind of quantify it based on what are the imaging manifestations of CAA on the rest of the brain. Do they have multiple areas of siderosis? Did they come with a second episode of acute subarachnoid hemorrhage? Both of those scenarios increase the risk of hemorrhage. We also know that they have considerably high risk of an ischemic stroke, just based on how common vascular risk factors are in these elderly patients. So it is a good target group to try something other than anticoagulants, probably. They are at the high end of the spectrum in terms of future hemorrhage, where probably many neurologists will feel uncomfortable putting the patient on an anticoagulant. So these are the patients that probably they might warrant a discussion with cardiology, if they have AFib, that is, to get a left atrial appendage occlusion device. And the idea behind it is that both CAA and atrial fibrillation are conditions that inevitably they're going to progress. So by considering an occlusion device early, it's probably a good idea to reduce, the long-term risk of both hemorrhagic and ischemic stroke. So yeah, it comes back to one of the thorny dilemmas in CAA, which is, what do you do when you have to anticoagulate?
Right. stroking versus bleeding, and I know the data is fairly equipoise as far as like, a low dose aspirin or like mono antiplatelet agent. I don't think the risk, if I remember correctly, isn't particularly elevated in terms of the balance between ischemic versus hemorrhagic stroke. Is that correct?
I think this is fair to say. There are no randomized data just on this population, but based on this rationale you mentioned, in some centers, instead of giving anticoagulation, they might give low-dose aspirin to at least mitigate some of the bleeding risk while gaining something in terms of preventing ischemic strokes. There are ongoing, so the ongoing trials in the field that they're randomizing patients with hemorrhage, intracerebral hemorrhage. They don't explicitly include these patients that they present with just sulcal subarachnoid hemorrhage and they have CAA. Only one of the studies in Canada initially included these patients, but they published a letter in Lancet Neurology saying that the interim review of their monitoring committee saw that these patients are at high risk of events when they're randomized to anticoagulation treatment. So they have stopped recruiting this patient in the trial. This was a trial looking on oral anticoagulation versus, I don't remember what was the other arm, aspirin or standard of care in patients with intracerebral hemorrhage or CAA. And they had these amyloid spells patients potentially. My reading of this is that probably even when multiple trials that are now ongoing are completed, we might not have a good answer for this subgroup of CA patients, either because they're not included or because the risk was too high to even randomize. So we might need to just go in the absence of evidence and discuss what would be the most rational and beneficial approach.
No, that makes sense. Definitely a very challenging clinical scenario that it comes up. Not super duper rare.
Yeah.
But yeah, no. I always appreciate every time we talk. I feel like I learn so much every time. So I really do appreciate it. Any final thoughts? Anything you'd want to share with our listeners today? Projects you're working on? Places they can find you online?
Yeah, sure. So I'm pretty active on Twitter or X. And I tend to post about these dilemmas or ideas about mechanisms, and you can share my email as well in your webpage. And if there are any questions, I'm happy to answer. I'm currently working on how to further improve diagnosis of CAA in different patient populations. Using cohorts of patients who had in vivo MRI plus neuropathology at some point when they died or when there was a biopsy. So I'm very open and seeking collaborations because we need numbers.
Awesome. No, we'll make sure to include your X handle and your email in the show notes for today. But thank you so much. I always really appreciate it. And I really did learn a lot today. It's definitely going to change some of the things I'm thinking about as I encounter these patients in the future. So thank you very much.
Thank you so much, because your questions made me think a lot. And you're asking like the pertinent questions about how to approach these patients and what might be the underlying mechanism. So yeah, I really enjoyed meeting with you again.
Oh, you're too kind. And for anyone who wants to find more, you can obviously check out our past interview with Dr. Charidimou about cerebral amyloid angiopathy and our other episodes. You can find us on all of your major platforms, and you can also find more of our work at theneurotransmitters.com. And you can find our podcast handle on X at neuro_podcast and myself at Dr. Kentris, DrKentris. Thank you again, Andreas. It's always a pleasure.
Thank you. Likewise.